Welcome to the Innovation in Healthcare podcast, produced by Health Innovation Northeast and North Cumbria, which supports the health and care system to accelerate innovation, to improve people's health and the regional economy. As part of our Medicines Optimisation work, the Medicine Safety Improvement Programme, or MedSIP, aims to reduce inappropriate high-dose opiate prescriptions for non-cancer pain, and supports better management of chronic pain across the North East and North Cumbria. In this episode, Victoria Strassheim, our Pain Workstream Programme Lead, talks to First Contact Practitioner physiotherapist Carrieann and Medicines Optimisation pharmacist Katie Meller. Carrieann and Katie collaborate in primary care and share the lessons that they have learnt to gain successful outcomes when encouraging the deprescribing of pain medication.
Hello there, I am Vicky Strassheim. I am the project lead on the Pain Workstream for the Health Innovation Northeast North Cumbria, and I support the running of the pain community of practice. I have with me today two clinicians. I've got Carrieann. Carrieann, would you like to introduce yourself?
Sure. My name's Carrieann. I'm a first contact practitioner in Brampton and Longtown PCNs, and I'm the team lead for Cumbria and Blackpool for primary care physio.
Thank you, Carrieann. And Katie Meller. Katie, would you like to introduce yourself?
Hi, I'm Katie Meller. I'm one of the Medicines Optimisation specialist pharmacists in North Cumbria, and I work for NEX, and I work very closely with Carrieann.
Thank you, Katie. So we have gathered today to talk about conversations with patients regarding opioids, particularly about withdrawal symptoms. This podcast can be listened to standalone. However, it links really well with the First Contact Practitioner opioid awareness video that was produced by the Health Innovation Northeast North Cumbria, and we'll link that into the information within this podcast. So without further ado, I'm going to ask my first question to you both. How do you both view the issue of opioids? Do you feel it's wider than just the NHS? Carrieann, if I come to you first of all.
Yeah, the patients don't just get these opioids on prescription standalone, so it's kind of wider than the NHS. But I think predominantly when it comes to picking it up as an issue, it would be picked up in the NHS.
Thank you, Carrieann. Katie, have you got any views on whether or not this is a wider issue than just the NHS?
Yeah, so we've talked about this before, haven't we, Vicky? But I do feel it's bigger than the NHS. It's wider than the NHS. But and I hope I'm going to explain this in a way that people will understand, because I've got this in my head, but I'm just trying to vocalize it. So what I'm thinking is it is wider than the NHS, but if you think about that person in the middle there with the persistent pain, it is wider than the NHS because their pain and the fact that they're taking all this pain medication is wider. If you can kind of imagine like a spider's web, I think of, and the person's in the middle, and then you've got all the spider web coming out, and you've got things like emotional well-being, and you've got family, friends, work, not being able to pick up their children, or not being able to do the hobbies that they want to do. So it is wider than the NHS. It touches every part of that person's life as well. So yeah, it's a massive problem.
Yeah, that's really well put, Katie. As you were saying,
was it? Are you sure it wasn't confusing?
No, because as you said that, a term came to me, a term called social diet, and that person who has the pain, who may be on opioids, is being seen by other people around them, and they influence, and there's that symbiotic influence that's going on. And I'd like to think we want to influence people positively, and no doubt, most people do want to influence positively. But if you're not feeling your best, that's a difficult thing to do, isn't it? So no, I think that you explained that very well. Thank you. So coming back to you, Carrieann, how do you see the role of the first contact practitioner in opioid reduction? Is there a role there for a first contact practitioner?
Certainly. A lot of these patients, when they've had, pain or circumstances that's required them to be prescribed any opiate, they're quite often then not regularly reviewed. So when they do come into a first contact practitioner, it's a perfect opportunity to ask them, why are they on that medication? Is it related to what they're presenting with, or is it related to an older problem that maybe hasn't been reviewed or picked up on, that they're still on that medication? And is it helpful? So yeah, I think we're a prime candidate to really pick these people up and see where we can help them to, to change those circumstances and see if that opiate is even helping. Certainly, I think it's a great opportunity for us.
Thank you, Carrieann. And what about you, Katie? Can you see, you've worked very closely with Carrieann. Can you see their roles being very supportive in this area?
Oh my goodness, yes, absolutely. It's funny how we all met, wasn't it, Carrieann? That we just kind of met up with each other almost in the corridor of the surgery that we're in, and just started having a chat. And it was then that we both realized that actually we've got the same goal. We want to help these people with persistent pain, and part of that is, trying to help them find alternatives to help their pain that isn't medication. So absolutely, physios are well placed to have these conversations. And I think as well, physios are lovely, aren't they? They're talking about ways to help with this person's pain, and that person would be very relaxed, I think, in that company of a physio. And that is a really good time to start to say, you're still in pain, and what's it like taking all these pain medications? And that's all you really need to do to start that conversation, and that's something that Carrieann's really good at, and because myself and Kirsty Casiera, who's the PCN pharmacist, and the technicians, pharmacy technicians that are there as well, they all do the same thing. We all refer to Carrieann and she refers back to us. So yeah, they are very well placed to have this conversation.
That's great. Thank you, Katie. And I get the impression there with that those conversations don't have to be very direct. It's just a broaching of, it's just an opening up the idea of, you're on opioids, are they really working for you? Not you're on opioids and you need to come off them. That came through very clearly, that it was we don't have to have an outcome here. We are planting a seed. Yeah, thank you.
Yeah,
thank you.
And I think that's Carrieann does it well, because she isn't, I'm talking like you're not here, Carrieann. she doesn't it doesn't come across as aggressive when Carrieann's asking, and that's what you need, because you don't want that person to become defensive, because we're not being judgmental. They're in this place because they've got this persistent pain and it's absolutely horrendous. So yeah.
So Carrieann, coming back to you, because we've heard, you've been picked up here, so we're going to have to go there. How would you approach that conversation about an opioid prescription with a patient? What would your dialogue, what might it sound like?
So, I mean, as Katie says, it's coming across in a very non-judgmental, open manner. It's asking a patient, why they're on it in the first place. Is it for an old problem? Is it for a new problem? And I think addressing if it's helpful or not. I think people ask, what you're taking it for? And then they stop the conversation there. When really you should be asking, is it actually helping? Or do you just have it by the kettle and take it every day routinely with your other medications? Do you take it because you actually need it? But it's putting it across in such a manner that you kind of make the patient realize for themselves that they might not need it anymore. And they have just been taking it routinely, or it's just not helping their symptoms anymore. So it's letting them kind of reflect on that and come to that decision themselves, and then offering them help if they would like to change it or come off it altogether.
just to open up that conversation a little bit more, you may be tempted to say your opioids may need to be increased, but that's not necessarily the case, is it? It's, sometimes the opioid prescription itself is the cause of the hyperalgesia. So it may well be that that opioid is making the problem worse.
Yeah. So how long have you been on it? I don't often use the word opiate at all. I always say, I'm always asking them, what are you taking for your current pain? Because I'm doing a current subjective examination there and then. And I'll say to them, so what are you taking for your pain at the moment? How are you managing, or what you're doing for your pain? And they'll say, well, I'm doing this, but I'm also taking gabapentin. And I'll say, well, you just recently been prescribed that, or is that something you've been on for a while? And they might say, oh, well, no, I've actually been on it about 10 years. And I'll say, all right, is it helping your pain at all? And they quite often say no. So I ask them, what's their habit of taking that medication? How often they take it? Is it just a routine thing? And then I also say, are you aware that might actually be causing you pain? And they nearly always say no. And we discuss the type of medication that it is and the side effects you can get from taking it long term. And then I offer some input. So I don't kind of make a decision for them. It's a very open conversation. Quite often it's a conversation where I say, why don't we just leave it just now? And then next time I see you, or you can go away and think about it, please do come back to me, because I would like to help you with this. If you don't want to go back to sometimes they don't want to go back to the GP because they think it will get stopped altogether. So it's about having that conversation, that it's their decision and it's a joint decision, and it's just very open and calm and honest, really.
I just liked what Carrieann was saying there, that sometimes the people with persistent pain, they don't want to go and see a GP. They may not even want to speak to a pharmacist because they feel that we are going to be the ones that will stop that medication. So that's one of the big reasons why it is great for physios to have this conversation, because it's relaxed. I mean, we try and be as relaxed as we can when we're talking to patients about it. We're not going to force them to reduce their opioids or their gabapentinoids unless there's a safety issue, because safety obviously comes first. But there is the shared decision making within that.
Thank you. So it sounds like a really good forum for a very therapeutic, open discussion to understand more about that person, that situation, or about those biopsychosocial circumstances before you move on, and the patient is in control. They've got autonomy there. Yeah. So, Katie, is there anything, would you broach a conversation any differently to Carrieann from a pharmacy point of view?
No, it would be very similar. I think years ago, when I first started doing these reviews, I would go straight in and ask them about their opioids. Tell me about the morphine that you're taking. But now I don't do that, and I think that's what Carrieann was talking about, is that I ask about their pain. Tell me what your pain is like. Tell me what it's like living with your pain day in and day out. Tell me what it's like taking those pain medications, and that just opens up the conversation. And you can learn a lot from that. And I think you've also got to remember, and I know that maybe physios are thinking, oh goodness, I can't ask them about their medication. I don't know anything about medication. They do know bits about the medication, but you don't need to know a lot about it. You have to remember that there's an expert in that room, in that consultation, in that conversation. And it's not the physio, it's not the pharmacist, it's not the GP, the clinician, it's the patient. So you're going to get all the information from the patient that you need. And if there's anything you can't answer, you can refer on to the pharmacist. And that's why it's great collaborating with different professionals within the surgeries. So yeah, I would broach the subject in a very similar way to Carrieann.
it was almost like a chance meeting that you two got together. It's almost romantic, really, isn't it?
Yeah.
So you two got together. So if there is an FCP out there who's thinking, oh, how do I do that? How do I contact the best person? Or if there's a pharmacist out there thinking, how do I go about like connecting with like the physio involved here? Is there a forum for that to happen, or is it you wait by the kettle for long enough and somebody's going to get thirsty?
I was going to say
Yeah.
it's the staff room.
I think it's very hard for people these days when you go behind a clinic door, you've got a day load of, if it's anything like mine, I've got a patient every 20 minutes. Quite often run a wee bit late, which digs into your 10-minute admin slot here and there, or it might dig into your lunchtime. So it's very hard these days to get out from behind your door and speak to other clinicians. So that's what I would say is make the time to go and sit in a break room at lunchtime, make the time to go and chat the door and say, I've got a lot of patients on this medication, but I don't know a lot about this medication. Could you help me refresh some of my knowledge? But could you also maybe help me get them off it? And that's exactly what we did. I think being a little bit nosy into why people are taking them and that want to help them not take it, because it's not good long term. We all know that. It just, we have the perfect opportunity to that, being first contact. I think some people think it's maybe outside their remit or kind of not in their job role, but it is. It completely should be. And it's getting people to think outside the box a little bit and go and have these discussions outside their clinic door.
Yeah, that's great. Thank you, Carrieann. It's those water cooler conversations, isn't it? That's perfectly summed that up. So my next question is, so you both sound very, very expert at having these conversations now. Carrieann's shaking her head. Well, that's a good thing, Carrieann, because I find in my practice, I learn more when it goes wrong than I do when it goes right. So just to say out there, so when have you got experience of when the conversations have gone badly with the patient and why it went badly and how you've resolved that? And do you still have episodes like that? And how do you pull them back?
Yeah, certainly. And it's more often you say to them, can I just ask why you're taking this medication? And I'll give you a particular example. I had one lady who just all of a sudden broke down in tears. She genuinely thought I was literally going to stop that medication that day. That's it. You're not getting it anymore because we've had one conversation about it. And I said to her, I said, well, kind of, whoa, let's just bring it back in a little bit. I only asked why you're taking it and can we talk about it a little bit? And we did talk about it a little bit and we decided to leave her on it and not deal with it there and then in that one appointment. I brought her back in, I reviewed her from a physiotherapy point of view. And then I said to her, how do you feel about this medication still? Would you be open to a conversation? And that was all we did. And we opened up to a conversation where I transferred her over to the pharmacy team, and I messaged the pharmacy and I do let them know she is quite anxious about this medication being stopped. And we just opened the conversation. But there have been times when people are even the opposite, when they've came from the pharmacy team to me and they've sat down and went, don't know what I'm here for, don't even want physio. And I've said, well, could we talk about it? Could you tell me why you don't want physio? Well, I went 15 years ago and they made me worse, And I said, well, a lot's evolved in the last time you went to physio. I'm a different physio from the last one you saw. Everybody's different. People connect differently. Can we just open the conversation? And I always say to them, how about we just chat about it? How about we just start simple? I'll give you one exercise. How about we try it? You don't have to complete it. You don't have to come back, but let's just try it because their options are very, very limited. And I think a lot of them know this, that when we are deprescribing, from a safety point of view, as Katie said earlier, that's the first and foremost, that if we are deprescribing, they've no other choice really, but it's not making it that final for them. It's letting them know that, from physio, we've got multiple choices and treatment options and trying to give them more of an open, optional pathway rather than, right, we're stopping your medication, off you go. Here's some exercises and self-manage at home. And it's making it personal to every single person. I think that's a big thing for us. We do make this personal. We sit down and talk about, how are the kids, how are the grandkids, what have you been doing recently? Have you tried any new hobbies? Now your pain might be getting less. Or what hobbies do you want to get back to when your pain is less? you know, and making it personal to them, because it really does get them on board if they feel like they're being listened to.
That's great. Thank you, Carrieann. Katie, tell me when it's gone badly wrong for you, just so we know that it's out there, that it does happen, that, you know, that, and that you can come back from it.
It does happen. And I think, again, when I first started doing this, my thought about it going badly wrong would be that the person didn't reduce their opioids, and I couldn't get them to reduce their opioids. But then I realize now that actually that was a good conversation, because we've talked about their pain, we've talked about the pain medication, and the fact that they didn't want to reduce at that point, that's okay. It was still a valuable conversation to have, and I think that's what I want to get across today. It is a valuable conversation to have, even if they don't want to reduce at all. So now, if it's gone badly, it's usually like I said before about the spider's web. There's so much involved in their persistent pain that if I'm then talking about possibly taking away this medication that they've depended on for such a long time, it is frightening for them. And sometimes emotionally that comes across as anger. So it can sometimes be quite a fraught conversation. And I think when that happens, it's very difficult to have that natural empathy. So if somebody is making a decision that you agree with and that you might make in your life, you have this natural empathy towards that person, and you can understand what they're going through. But if they're doing something that you maybe might not do, and we all have different experiences in life, and that's why we make these decisions that we do, you have to think about this thing called cognitive empathy. So you need to start thinking, you need to almost take a step back and think, why is that person acting in that way? I can think of many different circumstances when that has happened, when the patient gets very angry about reducing their medication. And it is exactly what Carrieann said. You take a step back and you listen, and you repeat what they've said so they know that you're listening. And then that can just help them relax a little bit. And then, you know, it might be you might just need a little bit of space, and you just think, okay, well, you know, I was going to speak to you or see you in a couple of weeks' time. Let's leave it a month, you know. So they might feel just that, you know, we need to support them, but there's that fine balance, isn't it?
Yeah, and I think I am definitely getting the impression, listening to both of you, that people are out there and they've got quite fragile existences. And if they feel their opioids are just about what's keeping them functional, and if it was to be removed, they were going to lose some role or function in their life, you can understand why they might feel a quite strong response towards that. The other thing that came into my mind as you were both talking was the make every contact count, so that we know there's an awful lot of opioid talk in the health ecosystem at the moment, and we don't know whether or not you're speaking to that person for the first time or the third time, or, you know, is it 6 or 7 times before there's a potential that seed has grown. But if you're going in quite gently initially, it's like, oh, somebody's talked, oh, somebody else has spoken to me about opioids. Oh, this must be something I might need to turn my attention to in the future. So the next time that conversation happens, and it might not be with you, it's with somebody else. Carrieann, you've got something to say. Come on.
I think you're right. Every contact counts, but also the way people put education across, because it's educating that patient on why they're on that medication, the outcomes of it, the symptoms of it, what we can do to get you off it, and things like that. It's all well and good, you know, kind of spewing information to people, but it's putting it across in a manner that's short and sweet and easy to understand for them. So I think, we can all be very clinical and academic in the way we talk sometimes, but giving these people kind of information that in one sitting is sometimes just far too much. So when Katie said, sometimes we don't get them on board, I'll be honest, quite often they do come back and we do sit and talk about it again, and we do sit and talk about how it's going to affect their life and how it's going to affect their circumstance and, their spider web, so to speak. So yeah, I just wanted to say sometimes it is how you put it across. So sometimes practicing on other people and listening to yourself and how you come across can be quite good. And it gets people on board a lot better than just, reiterating information.
That's a really valid point there, because I think, if we're all having these conversations, it's that drip, drip, drip effect. And we'll all come at it from different angles. And we've all had patients where we can connect with them, and those patients where you just know that your OT colleague or your psychology colleague is connecting better, and that conversation will come better from them. So yeah, absolutely. It's sort of having your expectations and knowing the rapport you've got with that person. Yeah, that's really valuable. Thank you, Carrieann. Right, my next question is, how would you explain symptom withdrawal? So patients on opioids, they're going to withdraw from them. And I think that fragility of a person's existence, them coming off a opioid or a pain medication, and how would you alleviate or try and reassure them about the opioid withdrawal symptoms? Carrieann, if I come to you first.
Sure. I don't go into as much depth, obviously, as what the pharmacy team would be, but I do make the patient aware that the pharmacy team will do this much better than I can. But I quite often keep it quite light. They ask me, is my pain going to go through? That's the biggest question. Is my pain going to go through the roof when you start reducing this medication? And I quite often kind of relate it to other things. If you stopped sugar, you'd have symptoms, or if you stopped kind of, walking, you'd have symptoms. Everything comes with side effects in life. If you stopped seeing a certain person, emotionally, you would have side effects. Everything comes with side effects. It's how we address the side effects that can make it much easier. And that's when I kind of reiterate, that's why physiotherapy comes to in play. We can address you with physiotherapy and do things to help you out with physiotherapy that can help reduce these side effects. So whilst Katie can clinically explain them a lot better than I can, I tend to find that a bit of a negative from my point of view when I'm trying to get them on board with physiotherapy. Just kind of turn it back around a little bit and say, we will address those side effects and we'll keep on top of them and make this an easy route as much as we can.
That's brilliant. Thank you, Carrieann. And Katie, what about you? How would you explain them?
So it would be quite similar to the way that Carrieann explains it, because I suppose not many people want to know the pharmacology of how it all works. So they do just want to know about their pain. So I think just going back a step is you need to find out what it is that's important to them. And it could be the pain, they'll worry that it comes back when they start reducing. It could be, I'm worried about flu-like symptoms or some headaches or shivering, sweating, anything like that. So those are some of the withdrawal effects that you can get. But I would say that not many people get those actual withdrawal effects. A lot of anxiety is kind of in the withdrawal. So they will probably feel some anxiety with the withdrawal. And that's not specifically because of the medication, the pharmacology of it. It's because they're feeling anxious about the whole withdrawal. So I would say, yes, you could get withdrawal symptoms. It is unlikely because what we're going to do is we're going to reduce this very slowly, and the person will be in control of that. And that also helps their anxiety, knowing that they've got that control over how fast they reduce the medication. Because at the end of the day, like we've all said, it's about safety, isn't it? If we can find an alternative way to help with their pain rather than the medication, then we will do that because that is safer. But we need to think about that person as a whole. So yes, withdrawal effects are unlikely to happen, but if we were to do it really fast, then yes, your pain would increase and you would feel horrible. You'd feel like you got the flu. But we're not going to do that. We're going to do it nice and gently.
Yeah, the emotional symptom that is possibly a side effect to the side effect.
Yeah.
Get it. No, that's really well explained. Thank you. And I think my final question to both of you is, why are opioid conversations worth the discomfort of having them? Because initially, whenever you do anything new, it's uncomfortable. So why are these conversations worth that initial discomfort?
Yeah, I don't find them uncomfortable. My role, first contact, as a physio or any clinician, I think we're in these roles because we do have a naturally kind of want to help people in general. And for me, I don't find them that uncomfortable because I genuinely think the majority of people are better off them. They'll feel better. And we've got example after example after example. And that's just the people that me and Katie and Kirsty and the team have been working with. They just make it worth it. People feel better. Functionally they improve with physiotherapy. And I don't necessarily find them uncomfortable. I think making a difference to people is well worth it.
That's a fantastic answer. Thank you, Carrieann. Katie.
I just feel I can't top those answers that Carrieann keeps giving. But I'll try. Yeah, I mean they can be uncomfortable at the beginning when you start having them. But I think what I want to come out of this podcast is that physios remember that the expert in the room is the patient. It's not them. So they don't have to have all that knowledge. So don't be worried that you don't have that knowledge. You can just ask them about their pain. And that's okay. That's not an uncomfortable conversation to have. And I think as well, have the support of the rest of your practice team. So I've learned a lot from Carrieann, and then vice versa. And also speak to your social prescribers, your care coordinators, your frailty coordinators, whoever you've got in the practice, and get the support from them as well. Because I don't think it would have worked as well supporting these patients with their persistent pain if we hadn't collaborated in the way that we do. It's great that everyone's sort of saying the same thing, and the patient is getting support from everybody.
Yeah, the patient's at the centre. The patient's the expert in their own life, and be guided by them. And I got a very strong sense of the outcome might be in the distance to come off an opioid and manage pain better, but that distance is dictated by the patient and the speed is dictated by the patient. Yeah, that's a really good place to end. Thank you so much, the pair of you. Can I just thank Katie Mellor and Carrieann Kirkup for coming onto this podcast today to talk about opioid conversations with patients from a first contact practitioner point of view. That was splendid. Thank you so much. Thank you.
Thank you for listening to the Innovation in Healthcare podcast produced by Health Innovation Northeast and North Cumbria. If you'd like to find out more about how we are supporting pain management and opioid reduction, please visit healthinnovation.org.uk/medicines-optimisation. We will of course provide further links and resources in this episode's show notes. Thank you again for listening.